Morning, everyone. I'm Dr. David Wild, Vice President of Performance Improvement here at the University of Kansas Health System, sitting in for Dr. Steve Seitz, our Chief Medical Officer. We're coming to you live from the Dolph Simons Jr. Family Broadcast Studio once again. With me in studio today is Lance Williamson, Supervisor in our Infection Prevention and Control Department, and of course, Dana Hawkinson, our Medical Director of Infection Prevention and Control. Good morning, gentlemen.
Hey.
Dana, how do we look heading into
Friday.
the weekend?
We are at that plateau that we had talked about as far as the total number, but also the acute number of infections as well. So 71 acute infections with 23 of those on the ventilator and 23 in the ICU, 15 on the ventilator. We still have 70 otherwise in that hospital in that recovery period. So it's a total of 141 patients in the hospital who wouldn't be here otherwise. As far as Hayes goes, they have 24 total, 23 in that active infection and 1 in that recovery period. So their numbers have kind of bumped up a little bit as well. But I think we are overall in that plateau, a high plateau. We'd certainly like it lower, but at least it's not climbing up into the 80s, 90s, 100s for those acute infections.
Yeah, the one caveat I'll throw out there is, as I was looking at the numbers this morning too, we have a significant number of tests pending from overnight still, which is not infrequent.
Yeah.
Just depends on what time people get admitted or patients hit the emergency department. So I think there were 13 or 14 that were pending still. Undoubtedly, 1 or 2 of them will be positive, but that's normal. It happens all throughout the day.
Yeah, and I think if you've talked about this before and probably know a little bit better about the admissions. So even though our numbers are about the same, that doesn't mean that we didn't have discharges and new admissions in the last 24 hours as well, and that's what this number doesn't reflect.
Yeah, lots of movement.
Yeah.
All right, well, before we jump into our discussion today, are there any reporter questions on the line?
Sure. Good morning, Cody Holyoke with KMBC 9 News. Good Friday to you.
Hi, Cody.
Hey, I know it's kind of a grab bag Friday, so I have a few questions for you actually today. First, would love your take on Pfizer study showing that their vaccine actually does fight off the new variants of the virus found in UK and Africa. We can go through it one by one, but second, I was just curious. I know that Dr. Seitz mentioned earlier this week, all health system staffers, the effort is now to get everybody a shot. How is that going? Are there people still turning down the vaccine? And then finally, I got a question from my co-anchor, Donna Pittman, who asked, is there any work being done to determine if we'll need a booster shot like we would for the flu each year? I thought that was a good question.
Great question.
Well, let's start at the top. So the Pfizer information released saying that there's not much concern about a lack of benefit from the Pfizer vaccine as it pertains to the 2 new variants of concern. Yeah. Dana, you want to start off there?
I tried to look through PubMed, which is our medical journal database, which has all of those. Google as well, because they have good references to those scholarly articles as well. The only thing I could find really are those news, mainstream media news reports about the research. It was conducted by Pfizer and a group from the Texas Medical Branch, the academic center. And what they said was that it looks like people who have gotten the vaccine have neutralizing antibodies to the variants. Now, we should understand that the main variant or substitution they were looking at was the 501 substitution. There is another variant or another substitution within those variants as well, particularly the South African one, which is a 484. And when I talk about substitutions, I mean a substitution at the amino acid site. That will change the conformation of the spike protein. That is what's scary. If you change the conformation or how the spike protein looks, you may not have antibodies that bind to those sites regularly. So the bottom line is that initial reports from the mainstream media, again, I haven't been able to find the exact article, but it looks like it is encouraging that you will still have antibody response and immunity to those variants with that 501 amino acid substitution. But again, this was people who were vaccinated, and then they tried to do neutralizing antibodies in the laboratory to that particular virus.
So I think the summary I would take away from that is this is not unlike early on in the vaccine trials when we heard directly from a manufacturer, from Pfizer, for example, that they had 95% efficacy, but we didn't have the data. It wasn't peer-reviewed, it wasn't published, it wasn't available for us to critique. And I think this is very similar, and that I think is okay. I think it's definitely better than a sign that there was concern
Correct.
in those studies. And so we'll take that for what it's worth, and know that it's possible and maybe even likely that there will be other variants that we'll have to go through this exercise with, and that the laboratory assessment that Dana mentioned, using these antibodies, neutralizing antibodies in the lab to see if they still bind to the protein, is not exactly clinical scenario, not how it works in our body, for example. And so there may be some difference there, but nonetheless, I think all positive signs.
Encouraging, yep. Next one was the mass vaccinations.
Yeah, so how are they going? So yesterday was actually our first day. We'll talk more about this and even, I think, show you some pictures at the end, because a lot of work going into vaccinating our healthcare workers here at the health system, just like in every health system and hospital across the country, and even in clinics arranged by county health departments for those healthcare workers who are not affiliated with a hospital or healthcare system. So we did increase our number. We've been doing about 600 a day most days for a couple of weeks now. Yesterday was a transition into our larger volume, our mass vaccination clinic. That clinic's able to do about 2,000 a day. So we were right around those numbers yesterday. I think 1,991 actually. And again, we'll show a little bit of what that looks like. There's a ton of work and a lot of logistics that go into doing that, also into keeping it safe. And we learned a lot in our first day, and so we'll use those things to help us as we prepare to move to other groups in the phased rollout, whether that be Group 1B or even phase 2, which would be more like essential workers, and then into the general population as time goes on. So lots of learnings there, but I guess, Cody, I would say going well. We continue to build our capacity.
There was a lot of excitement down there.
A lot.
It was fun.
And the third booster, yeah.
Yeah, I don't know. I mean, I think we all anticipate there will be a booster just based on natural immunity to the common coronaviruses, with the knowing that you can get reinfected with those common cough and cold coronaviruses at 6, 9 months, 12 months down the line. Also with understanding that with influenza vaccine, we need a booster as well, because there are virus changes with that as well. So I think there's an anticipation that there will be a booster, but all those plans and all that guidance is not laid out yet.
I will say we received a number of questions here from across the state of Kansas this week about a plan to begin redosing the vaccine at 3 months, at 90 days. And that just, I'm not quite sure where those started from, but I'm sure all of us have gotten questions about them. I got multiple. I think the answer that I've given, and I'm curious if either of you have a different opinion, was simply that is not the recommendation. We don't have any evidence to suggest it's necessary. It's not the plan, and we will be working on dose 1 and dose 2 for the population for much longer than 90 days, so there won't be any redosing 3 months from now.
Yeah, I think really focusing on there currently is the second dose booster that is recommended by both Pfizer and Moderna, and that is really important to achieve that 95% efficacy that they say. And I think looking back, it's quite an achievement. It's really, I was kind of looking back at some of the information I was going through in the spring, and, the FDA was coming up with guidelines on like what they would do if it was 50% effective, right? That's kind of what they were targeting. The fact that we have 2 vaccines that are over 90% effective is remarkable, and I think it's really great for us to utilize that and utilize it the way that they say that we should with that second dose.
Yeah.
All right, hopefully we covered your bases there, Cody. Any other?
Yes, thank you very much.
Yeah, you're welcome. Any other reporter questions on the line?
All right, we're going to rock and roll into our questions. I want to give you a few before we get to the slides. Isaac got up this morning. Hello, Isaac. Thank you for joining. And he wanted to know, he heard about sent us an article of a Florida doctor who passed after getting the COVID shot. Are they related?
Well, I'll start, and Dana saved me here. First of all, it's hard for us to say conclusively. I think we're not taking care of the patient, and so we don't have all of the information. I think we have seen an article or two on this topic, and before we get into the specifics about what was included in the article or not, I would actually answer it much, much more generally. When we look at a large population, whether it's a population of long-term care facility residents across the country, or everyone receiving the vaccine, or healthcare workers receiving the vaccine, without a doubt, there is the normal disease burden, not associated with COVID or the vaccine, that would occur in that population. There will be heart attacks, there will be car accidents, there will be strokes, there will be new cancer diagnoses, there will be deaths. Those things will happen, and temporally they may happen after a dose or the second dose of a vaccine, and it's very likely they were going to happen anyway. And so my generic answer, because I don't have access to this chart, is it's far more likely that this was a disease process that was happening anyway than it is that it's related to the vaccine. All that being said, there are very, very rare case reports of low platelet levels following other vaccines, and so it's not impossible. It's not me saying no, but we've had a relatively large population now that has received either in phase 2 or phase 3 trials, and then in EUA vaccination across the country, doses of both these vaccines, and this is, even if it is related to the vaccine, it's not a frequent occurrence. And the risk of something like this is so much less than the risk of severe illness or death from COVID. And so in my mind, it changes nothing about the conversation for the vaccines.
Yeah, I would completely agree. I think we kind of are at a disadvantage in the fact that we don't know all of the details about the case. There was just the media reports, but all the medical details weren't fully given to us in there. And we should also understand, just to your first point, there will be, unfortunately, people who die who normally we would expect they're passing. So, for instance, one of our other vaccine experts was talking to me about, we understand that there are high vulnerable populations, such as in the nursing home, that will be getting the vaccine. But you have to understand that out of every 1,000 people in a nursing home or those residents, there is a significant proportion, or a proportion of those patients that will die every month, or who will pass every month. And that has nothing to do with the vaccine, and that's just kind of more to your point as well. So it's really interesting. We would certainly like to keep on top of it. I'm sure the vaccine manufacturers, the FDA, the CDC, are all keeping on top of that. And once more details come out and we're able to understand that, that will be a lot better. But right now, it is certainly tragic, and we will just kind of wait for further information.
We might tell our viewers, too, that next Tuesday we have Dr. Lee Norman in Mario Castro, and on Friday we've invited Dr. Poland back from the Mayo Clinic, who's a vaccinologist, and he has agreed to come back. So
Great.
Yeah, and as time goes on, we'll have much more information about this, and we'll know and learn more from that. We'll be able to answer questions with probably more concrete results to support it. But at this point, yeah, I think it shouldn't change anything we're thinking or doing.
All right, Paul, a couple more quick questions. Paula says, is there a minimum wait time between the shingles vaccine and the COVID vaccine? We've had a lot of people ask us about
This question, comes up frequently. So
Yeah.
Dana gave an excellent answer last night to one of our colleagues.
Yeah, shingles too.
Yeah.
So right now the guidance for, again, Moderna and Pfizer vaccines is that there is just a lack of data on the safety and efficacy of giving those vaccines within 14 days of another vaccine, particularly shingles or anything else. What I will say, what we do in our clinics when we're doing pre-transplant, pre-liver transplant evaluations for patients, we regularly give multiple vaccines at the same time. Hepatitis B with the pneumonia vaccine, with the tetanus vaccine, those are all given right there at that moment, and that's not a problem. I anticipate that is going to be how it is as well, but right now the guidance is really to separate COVID vaccine 14 days either side of any other vaccine. So as more data comes out, it will probably shown to be safe and efficacious, but right now the guidance is really to separate any other vaccine from COVID vaccine for 14 days.
And Jane had a question, actually kind of a statement and a question about when we get to mass vaccinations with population. She said in 1951, we came through in our cars for the DPT vaccinations. And interestingly, she wants to know, do you think it'll happen again, that it'll be cars? I got a reporter that called me in Western Kansas yesterday, and they were doing that.
So definitely have seen pictures of vaccination clinics that included vaccinations being administered in your vehicle. There are a couple of things that complicate that here. In the first, I guess, is probably the biggest, and it's simply that based on the current emergency use authorization, there's a 15-minute observation period following administration. That can be done in your vehicle, but then that means that you need to have a parking lot big enough to manage those vehicles and enough people, healthcare providers, to monitor patients in their vehicles roving from place to place, and that the weather is under control, and just a lot of factors. Will we get to that point? Is it possible? I think so. I think several months into this, when we've vaccinated enough with each of the vaccine candidates that we're not needing such a long observation period, I think it's very possible. The second real barrier to that right now is, and we've talked about this a lot, is the logistics of handling these vaccines, the time from dilution, the cold storage requirements. As we get more to, say, the AstraZeneca vaccine that doesn't have those things, it will be much, much easier, I think. And I'm sure you both have thoughts.
Yeah, I think that's the hardest part, is operationalizing that. You know, it's one thing to vaccinate healthcare workers who are already in a space where they can be monitored by their colleagues, and we have the space here and the freezers needed all ready to go because we use that for other components of what we do every day. So it will be, I mean, all of this is going to be a lot of new operationalizing that really most of society hasn't seen in the scope that it needs to be for what we need for herd immunity. So a lot of this will be new. I think that's a great idea. Whatever we can do to make it as easy as possible for people.
Yeah, I definitely think the limiting factors here are the cold storage, but also the fact that we have to monitor you for 15 minutes, again, such as with shingles vaccine and HPV vaccine as well. We have done drive-through influenza vaccinations here at the health system in the university, so it's not unheard of. We would like to. That's more access for more people, but right now there's probably those limiting factors.
And I'm sure we have learned so many things, as I guess one of the silver linings through all of this, ways that we can do so many things differently. We've even seen respiratory illness clinics where breathing treatments are delivered in vehicles to limit interaction from people who are symptomatic with others in the clinic. So there will be things that we haven't thought of yet that will happen around vaccination because we've learned, because we have to, and those will help us in the long run. So I think it's one of those, if you can imagine it, we'll probably find a way to try it and see if it's better, and if so, we'll keep doing it.
Yeah, and keep imagining and letting us know. Katya wants to know why wasn't the mRNA vaccine approved sooner? If we've been studying it for 10 years, is there a fear that there are side effects we don't know about yet?
Yeah, that's interesting. So, and I've been interested in that too, because we have known about this technology for decades and been studying it. The thing is, you know, vaccine trials are expensive, and you don't get, a lot of times it's difficult to get people to participate in them. With this, it was all hands on deck. Everyone is interested. You have all the money you need. And so, you know, it's kind of like the best group project because everyone is focused on this one goal. And so really this was what was needed for this to get pushed through as quick as possible, because we know that it takes a lot of time, a lot of money. Sometimes you lose funding, you know, after a phase. And so it's really important for you to understand that is really kind of why this happened so quickly. And it's a good thing because now we have this technology, we're practicing it, and the rollout shows us that we can do these things safely and quickly, which is great.
Yeah, you know, I think the best answer is money and resources.
Yeah.
You know, they were looking at this RNA platform for other vaccines, including CMV, which is a common virus that most of us harbor in our bodies, Zika, RSV, all of those things, but are the money and resources there? They were looking at this platform, and this company, Moderna, I think we're looking at SARS and MERS vaccines as well. But again, the original SARS died out. Well, if it's not a problem anymore, it's going to be hard to get funding for a vaccine or a therapeutic for that. MERS obviously is still going on. They are still working on vaccines and therapeutics for that as well. So I think it's really the point that Lance brought up. money and resources. And there was just a huge push, and there was a lot of money, there were a lot of resources behind this disease to develop therapeutics and develop vaccinations.
Yeah, because it was a public health emergency, and the ones that you're talking about, that the mRNA is being used to study other
Right.
diseases, they're just not as high concern right now for most of the public.
And to your point, it is expensive to develop these technologies, to do the studies, to get people involved in those studies. So.
And the mRNA component of this vaccine is simply the delivery vehicle. It's the mechanism that it works, and so side effects related to mRNA versus an attenuated virus or any of the other mechanisms really, I think, is not the concern at all. And so if the question was, are we concerned about side effects, is that why this didn't develop? No, it really wasn't. When the rubber met the road, there wasn't the need for the funding or the drive, because lots of people were getting sick with the diseases that mRNA was being studied as a vaccine candidate delivery vehicle, and so it sort of took its course much more slowly than we've seen with this disease.
Okay, Wendy needs you to clarify on the 14 days, then we're going to go to the slide. She wants to know, you said 14-day separation for any vaccine with this one.
Yeah.
Do you mean 14 days before and after the 28-day period of the vaccine? And does it matter whether you got the shingles first or the COVID first?
Well, so shingles is a 2-dose. So if you get your first dose of shingles, I would wait 2 weeks before you get the COVID vaccine. If you got the COVID vaccine, I would wait 2 weeks before you get the first shingles dose. I don't see a problem moving forward with the second dose of either. For the shingles dose, I believe it's 2 to 6 months you can get your second dose, so you have plenty of time there. It's just separating those first doses out by 2 weeks. So hopefully that clarifies.
All right, we're going to go through our slides, and if we have time at the end, we'll go back to the questions from today. If I get the vaccine before my family, do I need to isolate?
So I think, so you don't need to isolate in regard to getting the vaccine, but you still need to participate in infection control pillars, such as wearing a mask in public, making sure you're doing good hand hygiene, and then following any public health guideline that is given to a family member based off exposure or isolation needs, anything like that.
Yeah, I think that was a good answer to that. Absolutely, we know that people can still get infected with COVID-19 or SARS-CoV-2. Looking at our second question here, but we know that you can still get infected, especially within that first 7 days. They looked at that in some of those studies, and after those first 7 days, even after that first vaccine dose, those curves start to separate. So you see less people getting infected after that first dose, after that first 7 days. So you don't need to isolate just from getting the vaccine itself, but you have to be wary and continue to practice those infection prevention measures.
And I'll be really, really, really clear. I don't know if this is the question, but I could see where it might be part of this. This vaccine cannot give you COVID-19. So you don't need to isolate because you're concerned that you will get the virus or become infected because you have received the vaccine. And so that would eliminate any need for isolation, separate, of course, vaccine from disease. So.
Yeah.
Is COVID-19 a disease or a virus? I hear it called both.
Great.
Yeah, COVID-19 is the disease that's caused by the SARS-CoV-2 virus. So these are two acronyms that we use to name these, the virus and the disease. The novel coronavirus is SARS-CoV-2. COVID-19 is the disease it causes.
Yeah, I think that was a very good clarifying question. A lot of times when we're talking, we just use them interchangeably. A lot of people say, I got the Rona, I got the 1.9, so any of those. But to be clear, SARS-CoV-2 is the actual virus.
Yeah.
COVID-19 is the disease and the symptoms that it causes. But mostly in conversation, a lot of times those will be interchanged.
I heard asymptomatic people can develop heart, lung, and other problems down the road, and I wonder, will the vaccine protect me from developing chronic COVID-19 conditions?
Well, this is a complicated question.
Our viewers always manage to do that.
Insightful.
So there is no doubt that people who have more severe infection, I know that this is not addressing the asymptomatic piece yet. So people who have more severe symptoms are more likely to have long-haul chronic disease from their infection than people who are asymptomatic. But there's at least in children a well-described condition where asymptomatic kids, so kids who are infected with the SARS-CoV-2 virus, don't have significant symptoms of COVID-19 disease at the time of their infection, 2 or 3 or 4 weeks later have inflammation of their heart or multiple systems throughout their body. That's called the multi-system inflammatory syndrome in children, or MISC. You may have seen or heard that. And that is very severe and an emergency, and requires hospitalization, probably even ICU care for most people. And we've seen some evidence that something similar can happen in adults. So it's possible that could happen in asymptomatic patients, adults or children, where you could have heart, lung, or other disease, other system inflammatory symptoms down the road. And then moving into, I wonder, will the vaccine protect me from developing these chronic conditions? I think the only answer, or maybe the best answer I can give now, is we would expect so, but we don't know.
Yeah, I definitely think that it probably would. Most of the people that develop these chronic long-hauling symptoms have those symptoms during the disease. So certainly we understand, just as Dr. Wild had said, that in asymptomatic people, you can also develop changes in your lungs if they can see it on CT scan. But I think if you're developing those long hauler symptoms, such as even things as simple as the smell is, my sense of smell is not coming back, or maybe some brain fog or shortness of breath, more than likely you were not asymptomatic and you did have symptoms. But we know, and we have seen from the data on these vaccines, that they do protect you from disease, and especially severe disease. So we'd expect your chance or your probability of developing those conditions is certainly much less with the vaccine.
My husband is a first responder who caught COVID-19 around the holidays. He hopes to transition home soon. Should he get the vaccine when it comes his turn at the department, or should he wait?
Yeah, that's a really important question. I'm not anticipating we will be, in a consumer market for vaccines at any point this year. So, I think if you're offered the vaccine, if it's your time to get the vaccine, you absolutely should. Even by the time that you're ready to get it, I think it's really irrespective of if you had COVID before. So, making sure that you, if it's your time in line, absolutely get it. That's what we want people to do.
There are a lot of questions around this concept. So I think that the general sort of question at hand here is, someone who's been recently infected should have innate natural immunity. They have their own circulating antibodies from their infection, and they will be provided coverage from that innate immunity for some period of time, 90 days, maybe even 6, 7, 8 months, looking more likely. And so there's a lot of discussion about whether those people should take a dose of vaccine, which means someone who maybe doesn't have natural antibodies circulating isn't going to get it as quickly. And that really, I think, is at the end of the day, the heart of the issue here, because we're not worried about a severe reaction to the vaccine if you've recently been infected or anything like that. So there's not a clinical reason not to get it. It's simply a resource utilization. As Lance mentioned, we're going to be doing this for a long time to get all of the general public vaccinated. And the CDC guidance is to, yes, vaccinate. When it is your turn, be vaccinated regardless of recent infection. And early on, when we had a much more limited number of vaccine doses than we do now, we were providing guidance to our team, even though the CDC said it was okay, to please hold off until we tell you so. Not because we were worried about them in any way, shape, or form, but because we knew they had some protection. Now we are vaccinating our own employees as we're getting a little bit more, a larger numbers of doses in every week. We have transitioned to following the CDC guidance even for our own healthcare workers. So I would say yes, absolutely.
How long do people need to wear a mask and social distance after they get the vaccine? How long? How many in the community need to be vaccinated before we can ditch the mask?
I think this is a question about understanding study design as it relates to how we looked at these vaccines. So the vaccines we're studying, or the researchers were studying if these vaccines prevent COVID-19, the disease, getting really sick from the virus. They really were not studying if you can just be infectious, have asymptomatic infection. And a part of that is because that requires a lot of testing, and at the time of these studies, that testing was not available. So I think that amount of testing was not available. So that was a limitation of that, I think, and really they were looking at trying to reduce severe illness. And so it's all theoretical that you are not going to be infectious if you get the vaccine. But we will need population studies to better understand that, lots of testing to understand that. And as far as the second part of that, so I think people need to anticipate that we will all be participating in masking and social distancing for better part of this year, and maybe even additionally after that. I think we can look at different models to try to understand how much of the population needs to be vaccinated. I know with something like measles, if the population dips under 90% vaccinated, we see outbreaks. Now, measles is unmatched in the way that it's infectious, and it's different than coronavirus, but we can look at that and try to, make conclusions. I've seen anything from 70% to 85% of the population needs to be vaccinated in order to achieve that herd immunity that we want to see. And I've also heard, 330 million people in the United States. We need at least 200 million people vaccinated in order to be close to that.
Yeah. I think it just highlights we are not out of the woods here yet. We've said that repeatedly this week. We've talked at length about the fact that vaccines will not mean at the individual level that you can behave differently, that these things are going to continue for quite some time, because the vaccine solution here, strategy here as a solution to the spread of this disease is not an individual thing. Yes, it prevents you from getting disease or severe disease, but the reality is the vaccine strategy is a population-based strategy, which means we need that 200 million or more. I would suggest it's more likely to be more, 250, 280, something like that, to really be comfortable that we can begin to relax the other mitigation strategies, non-pharmaceutical, right, like masking, physical distancing, all those extras. So. Long haul.
That's the $64,000 question. When can we ditch the mask? And I don't think we know that yet.
Yeah.
We need a minimum of those numbers vaccinated before we can even talk about it.
We have quite a few people who are curious, going to deviate from the slides for a second, about how long this vaccine lasts. There's one woman who says that her health department said it's only good for 3 months.
That's that question I mentioned we were getting from across Kansas a lot. Will we be redosing in 3 months because that's as long as the vaccine lasts? And I would say we have no evidence of that at all. What we don't know is how long it actually lasts, because we've not had, people who've been vaccinated for 9 months to know, even in the early trials. So the best answer we can give is we don't know, but it's not recommended anywhere that I've seen, nor is there evidence to suggest that it would be if we had the inventory, that it be in 90 days.
All right. Yeah. And I'm sorry I didn't listen well. You wanted to add?
Yeah, I just think we need to do that research still. It is so new. The vaccinations are so new. We need to understand that. They looked at antibody titers and T-cell responses initially, but as we get further out, 3, 6, 9 months, we don't have that answer yet. That will be looked at. And just remember, even though your antibodies do wane, meaning they decrease in concentration in your body, you still have that memory aspect. So you still have the cells that are able to make that can be mobilized quickly. You still have those T cells, the other cells in your immune system, to help and react to the virus when it is seen in your body. So we don't have the good answer to that. I would say, though, it's probably better than 3 months. I don't think there's any talk of having to do a booster at 3 months or 6 months or anything like that. I would think a year would be the minimum, but again, we're still waiting for that.
A lot of people are asking about the Johnson & Johnson vaccine, saying it's only 1 dose. What do you know about that?
Well, what we know, I guess, at this point is what we've heard from the manufacturer. There's no EUA application, there's no approval, and so that is the design of that vaccine. I think there's always the goal or desire, maybe, to land on a single dose vaccine, regardless of the disease or the mechanism of delivering that vaccine. But at this point, I'd say until we have published data that tells us a lot more about the vaccine, it's hard to know.
And I can't remember what they either use vesicular stomatitis virus or the adenovirus vector to get that. I don't remember exactly which. I believe it's non-replicating as well. We don't have a lot of information about it, but if it is one dose, that's great. If it is as efficacious, that's great as well. But we have to remember, as we heard Dr. Pahoud saying, you know, the AstraZeneca is really good because it can vaccinate the world, because you don't need those cold storage things. So as we get further into this and more companies are able to produce efficacious vaccines, certain situations will be better for some than others. The goal is to mass vaccinate, really, the world population.
All right, are vaccination clinics being considered for college campuses?
Well, I think the short answer is yes, when it's time. It will be some time before we get to what we would say are non-high-risk patients. And whether that's this semester, I think it's probably unlikely, but this year maybe. And when it is time, I think, of course, we would be wanting that. It's a group of a young age, of course, but a group that spends a lot of time interacting socially by design, and so there's always a risk there. And although we didn't have significant challenges, lots of work went into keeping the Lawrence campus safe, for example, this year. While we didn't have significant challenges there, a mass vaccination of the college campus would be an excellent way to help manage disease spread. So when we can, I think.
All right, it takes 2 weeks for the flu vaccine to kick in. How long does it take the COVID-19 vaccine to take effect?
You know what I mean?
Yeah.
So, yeah, I mean, most vaccines, it takes time for your immunity to ramp up once the vaccine is injected into you or once you eat it, if it's an oral vaccine. So it does take that time for your immune system to identify, recognize, and then start producing the antibodies or the T-cell responses against that. We know that within the first 7 to 10 days after you see the real infection of SARS-CoV-2, you start to develop antibodies. And by 14 days to 21 days, most people have detectable antibodies. The same thing is true for the vaccines as well. It will take that time to ramp up. But we also understand that you are not fully protected really until 2 weeks after that second dose of the Moderna and Pfizer vaccines. So it is that 14-day period even after that second dose.
Okay, could there be a strain of COVID-19 not being picked up by testing? The woman who writes this question said, I was diagnosed with viral pneumonia, but multiple doctors say recent x-rays indicate I had COVID, although my test came back negative. Whatever I caught is going around my husband's workplace, and several have taken sick.
Another complicated question. So start off, Lance.
Well, yeah, I think, so if you're getting molecular testing or PCR testing, it's unlikely you'll get multiple false negatives or even false positives. And if so, it's probably related to technique, whoever's collecting that, things like that, those things can happen. I think you should absolutely trust the test, especially if you're getting it, in a healthcare facility and it is a molecular test. Those quick tests, I think the evidence is a little less, we're a little less confident in that, but I think it's unlikely, the question that she's asking, I think it's unlikely that we have tests that won't pick up. And, we were talking about strains earlier, and I think it's important for the public to understand that anytime there's a strain or a new variant, your motivation, it's just more motivation for you to wear your mask, to distance, to not go to those gatherings, because we understand that mutations are fairly common with viruses, and mutations occur when new infections happen. So anytime you can do what you can to stop the transmission of this virus, you're also stopping a chance for a mutation or a variant.
Yeah, I think that we have to understand there can always be false negatives, just as there can always be false positives, any of the tests. And that is related to technique, as Lance had talked about, but also maybe during the processing. But understand that especially here at the health system, in our PCR or our molecular tests, those have two different targets on it that we are looking for. So the fact that both of those would be mutated so you couldn't identify it with the primers is very unlikely. We know that initially for the UK variants, they were having difficulty identifying infection because one of the targets wasn't coming back as, I guess, is high positive as the other target. So that helped them identify, and then when they went back in the sequence, they could find it. But the fact that you would have both targets missing is probably unlikely. So it certainly could be, but these targets to this in the PCR test to COVID or to SARS-CoV-2 are also what they have found to be fairly conserved regions, meaning they don't mutate as much as some of the other regions that we have seen or talked about. So it is probably unlikely.
Yeah, I agree completely. The strain probably has very, very little impact on whether you tested positive or negative based on what both Dana and Lance have shared. The second thing I would add is X-rays are not diagnostic for COVID-19. The pictures that you see on X-ray that show viral pneumonia or that show consolidation or ground glass opacities, if you've heard those words, that's sort of one of the ways radiologists describe what lungs look like. Those things can be present from multiple disease processes. In fact, if X-rays were enough to diagnose and tell you you'd have COVID-19, we wouldn't have the test. You wouldn't have to have the PCR swabs and all of these other things if they were diagnostic. So putting all that together, I'd say it's very, very unlikely, the combination. And of course, there are of the question of multiple negative tests and the fact that X-rays are not diagnostic. And simply because others in the workplace are having the same sets of symptoms, that's not surprising. Respiratory illness spread among populations, regardless of what the cause is. So it's very likely that you had whatever your husband's work was passing around, and that your testing is probably correct that you didn't have COVID.
And we have seen people here, very few that we have tested or they've been tested at the outside and they've come back negative. We still have a suspicion for it. The one thing that you can do to add to this, but I would talk with your medical providers, is also maybe at 2 or 3 weeks after your symptoms start, maybe check an antibody test. And if that's negative, then probably all those other negative tests before that with the PCR, the antigen, are probably true negatives as well. So there's ways to otherwise infer if that was a true false positive or false negative test.
We have 2 more questions. And our next one, I want to add in a little thing that Glenn asked. So the question as written is there any reason family members have to wait and take the vaccine together, or if one member has early access, should they take it? And adding Glenn's part, he wants to know, once you get a vaccine, can we have our own little bubble of people that have had vaccines and we're good to go?
Mm-hmm.
So as we talked before, you should, anyone in your family, if you get the chance to get the vaccine, get it. Don't wait. And then, as your other family members go through, they should get it whenever it's their time to get it. And as far as their own bubble, again, I think it's considering that you could still, we don't know if you could still be infectious or not. So, and we know that your bubble is only as good as it exists in that day, right? Because even reducing the what you're doing with your family could still impact other family members, the people that you have more casual contact with. So I would advise you to keep following what you're doing.
Yeah.
Yep.
All right, and this last question is, if a Missouri resident receives a vaccine at the health system, which state database records the shot? How does crossing state lines work? And Cindy Link is listening today, and she said her and her husband are 65, they have comorbidities, they're getting ready to go on their annual 4-week drive in the RV and see the world.
Yeah.
Are they going to miss their shot? They're worried about that. So can you address all of this? Last question, big one.
Yeah, more complicated answers. So I think the first part, where are those vaccines recorded? When we administer a vaccine here, we report it to the state of Kansas. Now there is, regardless of the vaccine, so Lance can talk about this at length around flu vaccination, but regardless of the vaccine, we report it to the state of Kansas. And then there's identifying information that helps direct to local health departments how many in their area may have received the vaccine. And sometimes that is cumbersome. Sometimes it's clunky even, but our responsibility is to report to the state of Kansas, and then there's a way for the state of Kansas to tell Missouri if a Missouri resident has received it.
Yeah, we deal with this a lot with reporting diseases and things like that. So since we practice in Kansas, what we do here is report it to KDHE. And KDHE then, they have an interface with other states and the CDC to understand, based off of demographic information, because we treat patients in Kansas from all around the globe, actually. So, anything that occurs here, because we practice here, will be reported to our state health department, and that includes the vaccine.
Yeah, and I think for the second part of that question, if you're 65 and you're getting ready to take your 4-week trip, right now the mass vaccination for the most part is not available to the general population. So I think you have time. What I would envision though is something, just like a prescription. If you go to one of those big commercial pharmacies like Walgreens or CVS, they have access to each other's, or they have access to other stores in their system, probably around the nation. So if you're missing medicines and you're out on a trip, you can probably get that. I would think and envision that same thing with the vaccine. If you're getting a first dose, if you've driven to Arizona, but now you're back in Kansas, and it's 21 or 28 days later, and it is available and there is access, that you can probably get it, and they have access to exactly which one you got and what day you got it. But right now, it's not available to the for the most part, in most of the states, it's not available to the general population.
Yeah. I think that's spot on. The network of local pharmacies, CVS and Walgreens, you've heard, I think, before, the vast majority of residents in the United States live within 5 miles of one of those two.
Yeah.
And that network will be hugely important in vaccinating the public as a mechanism, right? And so there will be a time when exactly what Dana describes is how this works. You can get dose 1 here, and then if you're traveling in Arizona for the winter, you can get dose 2 there when we're at that point of sort of your group being up. And the Walgreens and CVS partnership will transition from long-term care residents, right, the focus right now, to the more at-risk general population. And that will become, as I said, a very important mechanism there. So when it's time, I think that'll be available for you. I wouldn't worry too much about the next 3 or 4 weeks having too much of a challenge. And as always, if your group is called and you can't get it then, but can 2 weeks later, you'll be able to get that vaccine then. So once your group is called, you'll be able to get it at any point after that. Assuming, of course, that there is a dose available, but we anticipate that the inventory will continue.
Okay. I think we're running out of time, not out of questions, though. I will tell you that.
Well, thanks everyone for such great questions, and we joke about things being complicated, but we're very happy to try to work through those with you. So, coming up next week on Monday, Dr. Brandon Comfort, one of our internal medicine physicians, and Casey Pickering, our ICU nurse manager, will be here to update you all about our COVID-19 clinic, so our sort of chronic symptom clinic, and also what life is like in the ICU for COVID-19 patients. As we wrap up this morning, I mentioned earlier we were going to share some photos from yesterday from our mass vaccination clinic. Lots of work. I cannot explain to you how much work went into figuring out how to do this in such a short period of time. And this is all aimed at increasing our capacity to vaccinate more of our employees, and then to transition what we learn there into our ability to do that for essential workers and the general public. And this picture shows some of our nursing staff and pharmacists who did the test run as we were making sure that we had everything in place. And the second picture shows some of our first employees in this clinic getting their vaccine. And I think in all of these pictures, you get a sense of how large the space is. Very, very, very large rooms designed to be able to do 50 or 60 or 70 vaccinations at a time, and to monitor patients who've received their vaccines here and make sure everything is doing well.
Okay.
And so lots there, again, lots of work, so much work from so many people. We can't even begin to say thank you enough for our teams who have really, really worked hard to make that happen.
Can we pull up that last picture that Dr. Hawkinson, he actually took that picture and explained those tables, the way they're lined out. I mean, people might not understand, but is that just one person per table?
Yeah.
Yes. This is the observation room. So this is where you would go after your vaccination to be observed for your 15-minute window. There are 48 spots here, and I know, Dana, this brings back some memories for you.
Yeah, looks good. No, absolutely. I was just going to say this is just one room that we have to observe after you had your vaccine. So.
I think, we cannot say thank you enough as well to our partners at the University of Kansas Medical Center and the leadership team there. This is actually university space normally used for education in the university's health education building. So at the corner of 39th and Rainbow, that's the northeast corner, a new building. And the university has been gracious to donate that space and storage space and resources, technological resources as well, to help support this. I think another great example of how we partner with our educational components here on this campus to do everything we can to benefit the community. So thank you very much again to everyone on the university side of our campus who's helped make that real for us. Well, as we wrap up, Lance, any final thoughts this morning?
I think just get the vaccine when you're ready for it. That's really all that's on my mind lately, and I am really proud of the group here that has been working on that. My team and the teams that we work with every day. It's really heartening to do that work. So,
Dana?
The Chiefs have the week off and are staying home, so I would encourage everybody to stay home, stay healthy. We all want to ditch the mask. We can't do that yet, but enjoy the weekend. If you can, stay home. Wear your mask if you go out. Don't meet in large groups, and remember to physical distance.
Yeah. And I'll offer two things as we wrap up. I think I've said a number of times here, we can't thank enough our teams who have done so many different things. Today we're talking about mass vaccination clinics, but really it's been everyone here who's allowed us to provide whatever care we can for our community, and to try to rise and match whatever need that is. And it's pretty humbling and impressive to see what a group of people here who really are experts in their own right in lots of things can do when they pull together. I've been a part of a lot of great teams in my career, and this has been beyond impressive. And so for all of our teams out there watching, thank you. The second thing I would add is for everyone in the community and our teams. I know I mentioned it yesterday, but I have growing concern that we are not out of the woods here in Kansas City either as it pertains to infections and the impact on our healthcare delivery system. We are very full this morning, and while 141 of those patients are related to COVID, there are a lot of people needing care. And maybe it's very apparent to me today because I'm on transfer center call, and so seeing the requests that come in, but there is a significant need in our community, and we all have a role to play in making sure that we're able to offer care to everyone who needs it. So please, please, please remember all those pillars of infection prevention and control. As we spend so much time talking about the promise of a vaccine, those things are no less important today and probably are more important than they've ever been. So we crossed a milestone yesterday. It was our 200th update. I don't think any of us ever imagined we would keep an appointment with you Monday through Friday every day since March 19th to talk about COVID. But we have. And we'll continue to do that. We'll meet with you as long as we're needed. We've shared songs before on these updates from our vocal group of medical students called the Doctor's Notes. And we thought it very appropriate to share this with you this week. We'll stand by you. Please stand by us, and let's get through this pandemic together. We'll see you here Monday. Take care.
When the night has come and the land is dark and the moon is the only light we'll see. No, I won't be afraid. No, I won't be afraid. Just as long as you stand by me, stand by me. So darling, darling, stand by me. Oh, stand by me. So darling, darling, stand by me. Oh, stand by me. Oh, stand by me. Stand